I'm not going to spend a whole lot of time introducing the panel. I'm just going to say a couple of things about each of them, and obviously the bios are in the program. In this panel called Social and Environmental Determinants of NTDs and Technologies for Treatment and Prevention, that's a mouthful, we have Bruce. He's an associate professor of international health at the Johns Hopkins Bloomberg School of Public Health and director of the Global Obesity Prevention Center at Johns Hopkins and director of operations research at the International Vaccine Access Center. He has over 15 years of experience in industry and academia in public health operations research, developing and utilizing mathematical and computational methods, models, and tools to help stakeholders in their decision-making process. We also have Sahaja, is that?
Yeah.
Okay. Sahaja is a professor of philosophy and integrated biology at the University of Texas at Austin. He earned his bachelor's from Columbia University and his PhD from the University of Chicago. He's a specialist in conservation biology, disease ecology, and epidemiology, and the history and philosophy of science. He also has interests in formal epistemology and statistics, and author of numerous publications that you will find there. And then to the right of Sahaja, we have Lester Martinez. Lester Martínez-López is the president of Martínez Medical Consulting, a firm that provides consulting services in the healthcare industry. He was previously the chief medical officer at Brandon Regional Hospital in Brandon, Florida. There he provided leadership in optimizing medical staff performance and participation in quality, efficiency, and patient safety initiatives for a 407-bed hospital. And you can see the rest of his bio in your program. And finally, at the end, we have Carolina. Is that Carolina or Carolina? Yeah. Carolina. Carolina Batista is the regional manager of Drugs for Neglected Disease Initiative of Latin America. For several years, Dr. Batista has worked with public health and tropical diseases in various contexts in Latin America, Africa, and the Middle East. And over the past few years, Dr. Batista has progressively focused her work with neglected NTDs, most recently as the director of the Brazilian Medical Unit at the Médecins Sans Frontières office in Brazil. Welcome everybody. Let's make it a more dynamic panel. We have about 50 minutes. So what if each of you takes about 3-5 minutes to make some of your central remarks? And then I'll throw some questions at you, do a round or two, and then we'll open it to a Q&A with our guests. So why don't we start right here, Bruce?
Okay. Well, just some comments on some of the talks and discussions that I've heard. One of the key things to recognize is that economic arguments for resource allocation, for policies and interventions are very key. That, for better or for worse, that's how many decisions are made, and that's how constrained resources are allocated. The issues with neglected tropical diseases is that there is indeed economic arguments for developing more interventions, for shifting more resources towards policies and interventions, based on a lot of the studies that we've done and seen. The challenge is that the broad impact of NTDs has not been fully captured because there are certain diseases where the measurement is mortality or the number of deaths or things that make headlines, basically, number of celebrities who are infected or things like that. And NTDs don't fall into those categories. They are more subtle diseases. Their impact in some ways are more substantial because the sequelae of the diseases are deeply tied in with many aspects of society and many aspects of economics. So you talk about something like hookworm. The major outcome of that is anemia, and it's not going to be in many cases death, but that is a substantial sap on productivity. It can be a sap on cognitive development, education, et cetera. Those things ultimately in the long run are more substantial effects on society. They impact all sectors. They impact the whole band of society. And we're not just talking about low-income populations. We're not just talking about poverty-stricken populations. None of those populations are islands. They They supply the workforce, they supply the productivity for companies, for businesses, for all the business sectors. So I think really understanding how that ties together is key in helping various stakeholders really understand the impact of neglected tropical diseases. It starts becoming more of an argument. Traditionally the argument has been, oh, this is good for humanity, this is good, this is something that we need to do. It starts becoming more of a utilitarian argument. How is this really affecting your sectors or your country's ability to compete, your country's or sector's ability to actually produce? When you start casting it as that, then it starts becoming more personal or more, substantial to different stakeholders. They start saying, hey, hold on a second. We're actually dealing with something that can affect us. And from a utilitarian standpoint, might be something that we might want to address. So I think doing that can substantially help the NTD cause, because what we're essentially trying to do is shed light on the reality. That we're trying to connect the dots and tell people, look, this is really something that affects you directly, you just don't realize it.
Thank you, Bruce. Sahotra?
Thank you for having me here and for all of you for listening. My laboratory primarily works on mapping spatial risk of all these neglected tropical diseases. And we work mainly in Mexico and in Texas and on a variety of diseases. And we've come to it actually from wildlife conservation. That is, we were trying to come up with land use plans, and we were worrying about places which should be conserved because of all the endemic salamanders of Texas. And we realized those same places were also targeted for pesticide use in order to control for dengue-bearing mosquitoes. And how do you try to integrate all of these, and where are the trade-offs? And in trying to respond to this for a while, we had going 14 field stations, starting in Chiapas and ending in the Oklahoma border along a latitudinal gradient, working in collaboration with Victor Sanchez Cordero of UNAM in Mexico City. And we were monitoring each of these stations. And I'll say a bit about what exactly we found and how we did this at about 200 kilometer intervals all along. We've run into a lot of sociological problems, I would like to say now, which is that since 2011, several of these stations we have not been able to go back to, simply because of the security situation in northern Mexico, and that the state of Texas banned us as state employees from working or doing research in rural Mexico at that time. So there were problems that we encountered of that sort. And then we have also modeled all these diseases and the effects of what climate change might do to we do believe in climate change, that these diseases might have. And some results are interesting, others are what we expect. Interesting results, we originally did this for malaria in Africa, and then when we repeated it for dengue globally, is the disease burden will probably decrease as a result of climate change. That is, as there'll be range shifts of the mosquitoes, and we take into account how human populations are supposed to shift under different climate change scenarios, it turns out that less human beings are likely to be affected. That's one of the stranger results. The more expected results are that for tick-borne diseases, leishmaniasis, Chagas disease, the range of the vectors, and in the case of leishmaniasis, also of the relevant reservoirs, is going to expand northwards, going all the way into Southeast Canada. For Chagas in particular, we didn't think that the reservoir population really makes that much of a difference. There are reservoirs around all over the place. It's the vectors that are likely to spread, likely to spread in that way. What are the sort of risk insights that come from work of this kind? Well, we worry a lot, not so much about control of the disease. We are not qualified that much to worry about the control of the disease in individual patients. We are not medical people, but we worry about what kind of environmental factors affect the occurrence of the disease, that is, of you're getting bitten by the relevant vector. The vector is likely to carry the parasite and is likely to be efficient in transferring the parasite to you. Surprising results, take Chagas, for example, not true in southern Mexico, but true in northern Mexico, as well as southern Texas. The populations of the vectors of the triatomines are much, much higher in peri-urban areas, at the boundary between urban and completely sylvatic areas. Completely sylvatic areas, you don't get very many vectors. You don't get very many vectors if you are in completely urbanized landscapes. In between is the area that you do this pattern, repeats itself over and over again. How do we check this? From each of our study sites, we choose the middle of a village or something like that, and we lay out a transect all the way into the middle of a sylvatic area in 4 randomized directions, and we set up collecting traps all along. I think Christy Murray mentioned earlier, all of us have been getting amazingly high infection rates, higher in Texas for one of the species, Trichomonas teckeri, than any other place in the world, except Veracruz in Mexico, where the rates have even been higher for Chagas infection. The other thing, of course, we verify in southern Texas that the same things that were learned in various initiatives that were carried out in South America and in Mexico, that a high risk for being exposed to the insect is being in dwellings which are built of wood, and to a lesser extent in Texas, adobe. And so if you happen to go to a wildlife management area because you like to hunt or something like that, do not stay in their guest houses at night, which are often built of wood. You're likely to be bitten by kissing bugs. Things of that sort that have emerged from this work. But by and large, we are faced, and because of the relationship between Trypanosoma cruzi, which causes Chagas, and another Trypanosoma species, brucei in Africa, which causes sleeping sickness, we've also been worrying a bit about similarities in what we could learn from tsetse fly control in Africa to the control of triatomines in Texas and in in Mexico and Central America. They're doing a perfectly good job in the Andean region in controlling for Chagas these days. And the questions are that these are scientific questions that we have not been able to resolve. How do we manage for Chagas, leishmaniasis, tick-borne diseases, and dengue at the same time? But these are issues that have to be addressed because the efficient allocation of resources and also the acknowledgement that there will be lots and lots of use of the environmental resources for a variety of ends requires building up optimization protocols, essentially, so that we can take care of all of these at the same time. I'll just end by noting the ways in which things are just awfully connected to each other and make this kind of environmental management difficult. Probably all of you know about the imported red fire ant in Texas, which is one of the things that people worry about in terms of both getting bitten and of how much harm it's done to local wildlife, endemic species. The Houston toad is probably extinct, partly on its way to extinction, partly because of that. Well, the imported fire ant also is an extremely important predator of ticks. And so the presence of important fire ants actually decreases the prevalence of tick-borne diseases. At the same time, you have these along this zone and where you have permanent quarantine along the Mexico-U.S. border. You have an invasive species of giant reeds taking up. Strangely enough, this invasive species of giant reed helps you control for fire ants, which in turn increases the prevalence of ticks there, which in turn get into our deer population, and hunting leads to more and more cases of Lyme-like diseases here, and now we're seeing a similar pattern in the highlands in central Mexico. Let me just stop there.
Wow.
May I use some of this? I have some slides. Do you mind?
You
if I
may,
use-
please.
Well, I just want to talk to you. Actually, I can move the slides right here.
Yep. Use the little arrows.
Okay, I represent National Alliance of Hispanic Health, but I spent most of my adult life, 31 years of my life, in the United States Army. And my last posting was as a Commanding General of United States Army Medical Research and Material Command in Fort Detrick. And what is that? That's a stealth organization that is every day working on common issues on tropical medicine. Many of you don't know about this, so I would like to take the opportunity to bring you up to speed. Just on infectious disease, there's an effort of over 300 MDs and PhDs in the military addressing issues of soldiers, sailors, airmen, and Marines. We need to protect, that's the focus. We need to protect them, but we need to come out with diagnostics, drugs, and vaccines to protect them. And we have 5 overseas labs in Peru, in Thailand, in Kenya, in Egypt. I'm missing one, but it's okay. And so this is a history. If you go to the CDC and say, what do you need to go to Mexico? What protection do you need? Hepatitis A, a U.S. Army vaccine. Hepatitis B, a U.S. Army vaccine. Malaria, all the drugs for prevention in the world today, U.S. Army inventions. Oral typhoid, U.S. Army vaccine. Yellow fever is not U.S. Army, it was Rockefeller Foundation, but the seminal work was U.S. Army. You well know the story of Walter Reed and Gorgas and those guys. Okay. This is the pipelines of the vaccines that the military has developed, and it's the market everywhere. Now, why don't you know that the military did this? Because they have SmithKline and French. It says Sanofi. It says whatever, because we don't produce them. The military doesn't produce the drugs. The drugs are produced by industry. But the seminal work and actually the discovery and the making of the vaccine typically is the U.S. Army or U.S. military effort. So what's in the pipeline? Shigella vaccine. Is that relevant to Mexico and the world? I'll say yes. The most advanced malaria vaccine, RTSS, which, by the way, was in partnership with the Malaria Vaccine Initiative and the Gates Foundation. Think about this. Gates Foundation giving money to the U.S. Army to develop a vaccine. Okay? The most developed one is RTSS, is Walter Reed Army Institute Research Vaccine. Dengue, all the 4 dengue vaccines, including the one that we're talking today about, the Sanofi's Pasteur vaccine, all the SmithKline, all the 4 vaccines have been developed in collaboration with Walter Reed Army Institute Research. So the lead of the development of the antigen adjuvants and means of deliveries of the vaccines are military research. Now, we need to partner with the industry because we don't produce vaccines. So at the end of the day, the Army will buy from those guys, but everybody in the world will benefit from it. HIV, the most advanced HIV vaccine, the trial actually I put together in Thailand. It was a 16,000 subject trial, 2-year follow-up. It's the most effective so far, but it's not good for market yet. So the Army is working on some other ones. ETEC, Campylobacter. Malaria. Of all the drugs in the world in malaria, all but 2 are U.S. Army inventions. Quinine, South American Indians, we cannot claim that. And second one, artesunate, that comes from China. But in the pipeline right now, all the other drugs in the pipeline against malaria are still coming out from the U.S. Army. This is incredible. I mean, to me, I find this absolutely incredible. So, contribution and diagnosis. Scrub typhus. The diagnosis of malaria, not only we have means of detecting malaria in the insects and means to detect malaria field, not through microscopy. Field malaria testing in the field. West Nile detection in insects. By the way, DEET, you know DEET? That's a USDA, U.S. Army invention back in the 1950s. And if you want to talk about hookworm, you cannot talk about hookworm without going to Caleb B. Ashford, which was a colonel in the United States Army that went to Puerto Rico and discovered the hookworms in Puerto Rico and was the first guy to actually start working a solution for hookworms. So we have a big global surveillance system all around the world, and we collaborate with everybody, but quite often many of the findings are coming from the military. And I just want to stop right there, but I just want to sensitize you that there is a big stealth organization that is providing solutions for the world, even though the target was not the world. The target was soldiers, sailors, airmen, marine in the United States. The world is benefiting from that effort. And you should consider collaborating with the United States Army to advance this, just like many other people have done.
Thank you, Lester. Carolina.
Yes. Thank you for the invitation. Well, I would just repeat a little bit what I said just to start and just to place the NDI. So basically, the NDI, Drugs for Neglected Diseases Initiative, has its roots back to when MSF, Doctors Without Borders, volunteers, physicians, nurses were in the field dealing with the daily challenges of not having adequate drugs to treat patients suffering of some neglected diseases, some tropical diseases. By that time, most notably sleeping sickness, Chagas, and Leishmaniasis. So by 1999, when MSF, Doctors Without Borders, got the Nobel Prize, it placed that money to create a working group that would basically discuss the lack of innovation and the major gaps of innovation on research and development for the most neglected diseases. And that working group came up with a paper in 2001 that basically showed that from 1975 to 1999, only 1% of all drugs developed were directed to neglected tropical diseases, including malaria and tuberculosis. If you would take out malaria and tuberculosis, even less would be. So that paper was very important in placing those diseases in the agenda and saying, and that paper is known as the fatal imbalance, and really showed that there was an urgent need for a new paradigm in terms of R&D that could address those diseases, that the model, a market-driven model, purely market-driven model, would never address the needs of those patients living with those neglected diseases. So this new R&D model was basically what drove DNDI's initial representatives and these people coming from this working group to come up with a new model. And then some organizations and some academic institutions, such as Pasteur Institute, TDR, WHO, MSF, obviously, and some academic institutions from endemic regions such as Osvaldo Cruz Foundation, Kenyan, Indian, and Malaysian public health institutes came together and founded what is now known as the NDI, Drugs for Neglected Diseases Initiative. So the NDI primary objective by its creation was basically to develop drugs with a new innovation model for research and development that was not market-driven, that was not because it was very clear that those people suffering of these neglected diseases would never represent a profitable market. So the reason for the development of those medicines should be different. So basically, as the NDI, as the people behind this initial group, nobody had a lab. The NDI is not a laboratory. The NDI needed to make partnerships with pharmaceutical companies, with research institutions, with national programs, and of course, keep a good dialogue with non-for-profit organizations such as MSF and such as patient representatives from endemic countries. So to date, the NTI has developed already 6 new treatments for neglected diseases, including Chagas, Leishmaniasis, sleeping sickness, and 2 for malaria. All these drugs have been added to the WHO essential medicine list in an attempt to make these drugs more easily available in endemic countries where they're most needed. So basically, what the NTI has done throughout the years is also to coordinate the creation of regional disease platforms. And in the region here in Latin America, we were very strongly working with 2 platforms. One for Chagas disease that brings together researchers, national programs, patient representatives. They're very strongly, and the NDI has supported also the foundation of the first International Federation of Patients or individuals affected with Chagas disease. The other platform that is very strong in the region is for cutaneous leishmaniasis that now we're expanding to visceral leishmaniasis as well. So basically the role of this platform is really, really important because it has a very specific role of bringing these people together to define, since the first steps of the drug development, since the initial phase of the pipeline, which kind of target product profile we want. So it's important to have patients to understand, would you rather have an injectable treatment or an oral treatment? So, of course, the answers are pretty clear, but it's important for us to have different opinions from researchers and also from the endemic country national program so that we can tailor the kind of product that we develop to what's most adapted to the field conditions and to patients suffering of those diseases. And now, after more than 10 years, because the NGI has been created in 2003, when we look back, we see that this model has been very, very efficient to deliver treatments for those diseases without having the R&D huge costs and bringing the cost of the treatments high. So basically, the NDI very strong principle is open innovation. So the NDI doesn't believe in patent for protecting the intellectual the property of these medications. We believe that it's a public good, but now it's also the time to rethink what we want from now on. I mean, should we keep doing the same that we've done so far and we've been successful, or should we try to be a little bit more ambitious and maybe think about the new landscape of diseases? And I think this morning Dr. Holtes gave a very good explanation, the new middle-income countries and distribution of diseases, of the poor living in those countries. So the paradigm has definitely changed, and the NDI also believes that it's time that we change as well, and we expand. We keep the same vision of being an R&D virtual organization working with partnerships, but we should expand our mission and broaden our scope of action from neglected diseases to neglected patients. So we really would like now to focus and to have a more dynamic portfolio that can make us adapt more quickly to needs. So we're thinking of maybe engaging on non-communicable diseases, or having different roles in maybe have incubators of ideas and then have spin-offs to other organizations. So it's really a moment that we're rethinking our future, and we will keep the core of our activities to addressing the needs of the most neglected diseases, but also expanding and testing if our model can also be successful in that, and also working with different issues on access to medications. Because for Chagas disease, for instance, we have the very sad number that less than 1% of all infected individuals in the world have access to treatment. So we believe that our model of R&D can also be adapted to a model of increasing access, and maybe being a catalyst for change for access for neglected diseases. So I stay here, and then maybe we'll discuss further.
Karoli.
Thank you very much.
Well, I have a couple of questions. We'll do a round of questions. I'll ask a question of each of you, and then we'll open it to the audience. Bruce, recently we had an academic from Mexico visiting the Baker Institute's Mexico Center, and he and I engaged in a study on trying to understand border violence as or using epidemiological tools to understand border violence. And we try to quantify the costs. And obviously, when we talk about violence in Mexico, we often talk about 100,000, 120,000 people dead. But there's a lot of people that are maimed, incapacitated, disabled, psychologically damaged to the point that they can no longer engage in work, have to flee, have to sell what they have and flee to another country, another area at a discounted price. So there's some wealth loss. So the costs are just a ripple. And so my question to you, with that experience of my own research, is considering the burden of Chagas and all these diseases in both the U.S. and Mexico, and all the estimations and the underreporting and the reporting, how can we achieve good modeling of the economic burden of these diseases and get that estimation to bear on our public policy calculations?
Mm-hmm. Yeah, I think there's several issues. So one is that a lot of the metrics that have been used traditionally have been developed around certain particular types of diseases or problems. And because those metrics have been developed around those problems, then they naturally will favor those problems, which is not to say that they aren't valuable, but they may not capture the full spectrum. So there's a continuing need to, when you're building models, to really broaden the net and really understand ramifications. So there is an increasing understanding of this. For instance, over a couple years ago, Gavi held a value of vaccines meeting to discuss this. So Seth Berkley and folks at Gavi convened a relatively small group of experts. I was included in that meeting, where the discussion was, okay, we've gotten to the point where we've quantified the value of vaccines from a strict, okay, cases averted, mortality averted, but really trying to understand that broader impact. You know, how does it affect productivity? How does it really affect education and cognitive impairment and those type of things? So the discussions are starting. So people are starting to talk about how do we quantify this? How do we do this in a rigorous manner? And the techniques are there. I think it's just a matter of building the models and making them transparent. So making it clear, okay, we're accounting for these factors in this way, and allowing and really engaging decision makers to make sure that we're using metrics that they resonate with. Another challenge, a second challenge, is that some of the measures were designed for particular purposes. Like, okay, let's determine the number of dollies as an example. Dollies is useful because it is a measure that resonates with people who are interested in sort of societal disease burden, but it doesn't resonate with business leaders. It doesn't resonate with people who use straight costs or use profit and loss to really make their decisions. So again, while dollies is a useful term and it's a useful measurement, we need to start developing some of these other metrics that can then subsequently resonate.
Thank you very much. I know that Sahotra has a little crystal ball somewhere in there hidden, so I'm going to ask him to think about 2050. And obviously, one of the greatest conversations going on this year is global warming, and that's going to have effects. I was telling my master's students last night, for example, that what if all of a sudden northern Canada becomes actually fertile land that can be settled and by great populations, and other places become deserts and they have to be abandoned. So there's going to be consequences for diseases. There's going to be consequences for these vectors that will expand their territorial reach. And so the question is, what do you predict by that year in terms of what Mexico, Texas, and the United States will look like if we do not take action now, or if we take a certain amount of measures or actions, public policies now? Can we actually prevent that, or are we just going to be in a situation in which we will have to engage in simply solving symptoms, but never really anticipating what we should be expecting from global warming and potential climate change?
All right. I'm glad that nobody can tell me that what I've said is wrong. You have to wait till 2050, and with luck, I'll be dead by then. There are separate issues here. Probably for northern Mexico, central Mexico, and Texas, the most important problem will be water. Okay, it's already a problem even without climate change. I actually think probably the worst scenarios of climate change are unlikely. You're going to get something close to the A1B, the lowest change scenario, and that's bad enough. But water is going to be an immense problem, starting Texas downwards, at least almost up to the Guerrero border. The water shifts and all of that. As far as disease...
Sorry, water shifts from climate change, or water shifts independent of climate change?
Oh, they would happen independent of climate change, but they will be much worse under the climate change scenarios that we have right now. As far as the disease stuff that I was talking about, we have to be very careful about what we are willing to say and what we are not willing to say. Almost all attempts to predict what species will do under climate change assume that species have no plasticity, that behavior will not change. They just assume that ranges will change, and it's very difficult to take plasticity into account because the experimental work has in general not been done. But it's fairly clear that the drier climates will probably make mosquito-borne diseases rarer in some of these areas. But almost every other kind of disease is going to spread further and further north because there will be more and more suitable climates for vectors and reservoirs all the way up north. So there's a lot more we can say about what other things climate change might do under these circumstances, but that's the extent to which we have done significant modeling. In the Mexican case, there's going to be less of a change than in the U.S. because most of Mexico, what will involve is northward shifts from the southern border of Mexico as far as vector-borne diseases go northwards. But most of these diseases that we're talking about are all over Mexico already, anyhow. And the population changes in Mexico are far. The population change scenarios for Mexico are far more uncertain than what they are for the U.S. and they're all pretty uncertain.
Right. One question real quick for you as well, because violence and criminal organizations and such are part of my research agenda. You mentioned that you were not able to visit the stations that you placed along the route in Mexico. That's obviously been for every researcher. We have to now file all kinds of travel warnings and under our own responsibility travel and such. Do you see that changing anytime soon? Do you see that the conditions, so that we can effectively monitor that, will actually change anytime soon?
I think some things are changing for the better, but most of our sites are in extremely remote areas where we see things like we go into this really poor village, and suddenly in the middle of that, there is one villa that looks like a palace and an amazing restaurant over there that serves better food at prices comparable to Mexico City, and you know exactly where that money is coming from. And here we are carrying GPS units, we're carrying all kinds of advanced electronics to set up our monitoring and all of that. And of course, it looks very, very suspicious as to what we're out to do. Half the students are Americans. There's all kinds of stuff that's going on. But my sense is, at least in Tamaulipas and some of the other places like that where we've worked, things have taken a turn for the better in the last year and a half. They're certainly not as bad or dangerous as we thought they were in 2012, 2013.
Great. I have a question, Lester. One of the concerns about R&D done by the government is obviously that there are many things that come out of government research, from Velcro to the powdered orange drink. I forget the name of it now. I don't consume it. Yes, Tang and other things. And obviously you have shown that many of these vaccines and treatments are developed within the government. Obviously, a concern is that if they are not produced by the government and distributed by the government, they obviously are somebody's patenting these medicines, and somebody is profiting from these medicines, and somebody's putting a price on them. And recently we had the scandal of this CEO that bought a pill and then raised the price by 5,000%. Is that an impediment to get access to these pills? Is that somehow a problem to actually get the treatment to where it needs to go, whether it's by organizations, by individuals, by NGOs, by the governments and such? Is that something that who profits and who benefits from what is R&D done by taxpayer funding?
Well, if you think about almost every drug in the inventory, whether it's tropical medicine from the government or blood control medicines, you can trace some government investment in the initial discovery of any of the drugs are in the market. Still the structure, still the model is a profit model. So, the government actually sees this as an investment in the economy, and by these industries developing a profit, it revolves back to the government in form of taxes. So it goes into a reinvestment and the economy keeps growing. And that's been the American model of economic development. I don't know if the government is getting ready to change anytime soon. I doubt it. Now, said that, the drugs and the conditions the military will look at are conditions are orphans in the United States. If someone is investing in a condition in the United States, the government would not, the military would not get involved into that. So that's why we get involved into malaria and dengue and HIV. The HIV we get involved is the clades that are outside from the United States. So the focus is external, and the industries that are partnering with us, they understand that the market they're going to have to go to is not the U.S. market. So it's not the Canadian market and it's not the European market. It'll be the developing world market. So with that in mind, their marketing strategy is to come in at prices that will be logical. They're still going to have to make a return of investment, and they still have to, they have to respond to their shareholders. But they understand that they're not going to come at a killer price, and they're not going to come at an incredible cost. So when we start dealing with them, typically we go and do this research in other countries, like in Thailand, because we don't have dengue, or we go to Kenya for malaria. Those countries actually get into deals with it as a third party with the particular drug makers to come out with access to the drugs and fair price. So it's a long convoluted. It's not a simple equation. I don't think making a profit is a bad thing. Actually, I think it's a very good thing. The question is, what's a fair profit? That's a different story. And I think many of the companies, Sanofi, SmithKline, when they get into the market with us, they know it's a developing world market, and they know their prices are going to be, the return on investment will be very different if they're working on Viagra or something else. So
Yeah.
I have some of those concerns, especially when we bring other parties from other governments and stuff like that. And I've been very nicely surprised that these companies are acting on good faith.
Do you think that military laboratories can play a good role in tackling every one of these diseases, or will their activity simply follow the needs of military mobilization?
The number one need always, the need of mobilization will be number one. But, all these labs are national labs. So you have to look at them as gems. Example, the lab in Thailand has been there for over 15 years. The lab in Kenya has been in Kenya for over 40 years. The lab in Egypt has been in Egypt since the Second World War. And it's a continuous presence, even during good times and bad times. And they're doing all kind of work, and we're collecting all kind of data. Example, flu. How do we develop the flu vaccine in the United States? The Canaries are military guys all over the world. We swab them every time they come out with an upper respiratory infection. We send all those swabs to San Antonio, Texas, to the Air Force lab. They identify what flu strains are coming out. And based upon that flu strain data, that's how we develop we give that to the CDC, and the panel decides what the vaccine should be. So is that a military relevant? Yeah, I guess we don't want soldiers to have flu, that's for sure. But it serves the greater good. It serves the country. So I think they're really national. You have to look at them as national labs, not as military unique labs.
Thank you, Lester. And Carolina, in your opinion, what is the most needed technological intervention to reduce the impact of NTDs in the U.S. and Mexico? And how close do you think we are to achieving that technological innovation to truly tackle these diseases on a mass scale beyond community and small-time interventions here and there, even if they make an important difference? The technological breakthroughs to tackle this, where are we there?
Well, this is the $1 million question. I think that I wouldn't say that there is one technology that can, there is no magic pill. I don't believe that there is one technology that will solve the problems of, U.S. and Mexico or other countries in the region in Latin America. I believe that a comprehensive response is urgently needed. I think there needs to be a very close dialogue between organizations working with diagnostic tools, for instance, that they can develop a diagnostic method that can be applicable in the field. And if you go to a remote area in Mexico, like you were saying earlier, or if you go to a place with mobile population in Texas, coming from Latin America that are planning on going to the north of the country, and if you think of Brazil and Colombia, I think this is urgently needed, a very good diagnostic tool. The other thing is like treatments that are easily, taken in the field, also under field conditions, because basically, even if we think, now again, I will refer to the presentations in the morning, if you think of Houston and areas where people might not have the facility of going to health centers to follow up on treatments. So, having treatments that are easily to take, like maybe single dose or something would be ideal. And at the same time, a good surveillance system that you can actually monitor the response to those treatments that are delivered to patients. So I think it's really something that I don't believe there is one thing, so that's why I believe that the NDI's role is very important, but I also believe that working in partnership and working hand in hand with diagnostics and communities, also working on awareness raising in the communities and having those affected population as as an important actor in talking to policymakers, to physicians, and bringing them to the fight also, and saying, we need better tools that are adapted to where we are, to where we live, and to our conditions. So unfortunately, I don't believe there is one thing, but I really believe a very comprehensive and integrative approach is urgently needed to tackle neglected diseases or diseases of poverty.
Thank you. We have about 10 minutes, so I think there's plenty of time right here.
So for Lester, I actually wanted to expand even beyond what you were talking about, the involvement of government and / military, and you spoke, of course, early R&D, clinical, epidemiology, surveillance, but I have to also point out that, for instance, in vaccine manufacturing, in the US right now, the only one that's left that actually do nonprofit vaccine manufacturing is Walter Reed.
Correct.
So we, in our group, most of all our vaccines have been produced by Walter Reed Army Institute of Research, and those are the ones that currently are in clinical trials right now.
Thank you very much.
Unfortunately, we lost, the only other PDP that actually was still, having a manufacturing entity, and now they became for profit. And honestly, the prices have just increased because they now use a for-profit model. So for instance, in NTD vaccine development, we don't have a lot of options. The only option is Walter Reed, unless you try to attempt to go overseas, which is what we're trying to do, trying to work with the developing country vaccine manufacturers. But in the US, clearly is the US Army. So I think that we need to make sure that, we also see that perspective, I think. And they don't do it for their own military, interest. It's a global health interest.
In the long run, health is one of the major stability factors for peace. Think about that. Actually, one of the main reasons why the Army got involved in the HIV vaccine development, the argument is, if the epidemic of HIV kept on going in Africa, it's very destabilizing to all these countries. And in the long run, it will cost us lives. Not lives from HIV, but also lives from fights that we'll have to go over as a military. So there is a big strategy from the government thinking we need to do good in these areas to avoid crises and that we don't want to get involved with. So I'm very proud of the work of RARE, but I didn't talk about the work on biodefense, which is another effort as big as the effort on infectious diseases. And what do they have in common is they have common platforms. So, when you're talking about vaccines, what do you need a vaccine? You need a vector, you need adjuvants, you need an antigen, right? So there's many adjuvants that are common adjuvants, there are many vectors that are common vectors. There are many, the only thing different would be the antigen that you're working with. And even in the development of the antigen, the technology, how you develop an antigen, how you target a particular sector, to create an immune target. And all that, there's a commonality that is being shared by both the biodefense effort and the infectious disease effort. There's this boundary on selected agents that we put in the Department of Defense. Ebola being one, but Ebola is in the selected agent side, so it's about defense. But what we have learned, it goes across the board, and it spills to Sanofi Pasteur, and it spills to SmithKline, and it spills to the rest of the industry. So it's, again, very proud tradition that we need to sustain. The problem is if we don't sustain it, then we lose it, and once that Humpty Dumpty is destroyed, you don't put it together again.
Great. Another questions? Right here. And then back here, yeah.
So, especially in this panel, there's been a lot of talk about human vaccination and human treatment of neglected tropical diseases. However, a lot of times humans are dead-end hosts in these, disease cycles. And so if you take a step back and you look at the transmission cycle, there's been public health efforts to try and monitor and control these NTDs from all perspectives, whether it's the animal host, whether it's an intermediate mammal host, or human host. So my question is, what is the social, public health, and economic benefit of, for example, surveillance, which right now is severely inadequate in a lot of NTDs and a lot of times is reactive to human outbreaks, versus vaccination development in human hosts where sustainable transmission is limited?
Yeah.
Well, for some of the diseases that we're worried about in Texas and Mexico, clearly looking at the mammalian reservoirs is the easiest way to do surveillance. In particular, I have argued, but I don't have enough data to fully back it yet, is that we can find out about Chagas prevalence in Texas by just looking and sampling dogs all over the place. In fact, the U.S. Army has been interested in Chagas in Texas for a long time because they're worried about Chagas in dogs,
Absolutely.
not Chagas in humans. In dengue, humans are the reservoir and the host. So it varies by it, but it is true that for some of these diseases where the infection rate in humans is rare, it's going to be much more effective to track where exactly a disease outbreak is going to occur by look at other animals. Dogs are one. It's very easy to capture rodents. Rodents are very good ways to find out where Chagas / Leishmaniasis, both of them can be present. Sometimes they're present at the same time. It's also true that Chagas, for example, has occurred in every primate center, not only in Texas. We did a literature survey last year, but in the southern U.S. And so, yeah, these problems are all out there. And of course, the various primates have been used as models in attempts to develop human vaccines. But it is an important part of the cycle. We don't try to ignore that.
It was driven into my head when I went to Hopkins by a great professor, Susan Baker, that the disease model is really like a triangle. So at this end, you have the agent, but the virus or the whatever it is. You have the environment, including the vectors, and at the other end, you have the subject, right? So to have a disease condition, the three of them have to be linked up. If you break the link up in any of the three of them, then you succeed. There's no disease. So you may have, if you have the vector and you have the environment, and the agent, the dengue, let's say. You have dengue, you have the mosquito. But let's say I have a vaccine that now I immunize the host, and the host is immune, the mosquitoes can bite all they want, you're not going to get dengue, right? So if you follow that model, what the surveillance system allows you to do is to target. So think of a surveillance system as a target on a rifle, right? So if you're shooting and you don't know where you're shooting at, you may hit what you meant to hit, but typically you don't do that. But if you have a way to direct your actions, right? So you know where, how, your target, right? Surveillance. Now you can aim it with a particular, with whatever intervention you think would be most appropriate. And I agree with you. Typically, it's not one intervention. It's a combination of two interventions in two of the chains that is the most effective at achieving the goals that you're trying to achieve. So there is a lot of studies, but I'm very grateful to Professor Baker because she's been trying to drive this into everybody's head that think you have to this is an engineering concept, deconstruct whatever disease you're trying to aim at, look at the three components, look at the targets, look at the interventions based on the targets, and then have a surveillance, targeting system that monitors it out and do the intervention. This sounds very simplistic, right? But that's the way it is. So I'm just thinking that surveillance is your targeting.
Thank you. Bruce?
Yeah, so to add on that, we shouldn't look at these different interventions as different silos, like, do we choose door number one, door number two, door number three? The economic value of interventions can be quite synergistic. So you can actually have situations where a vaccine becomes more valuable because you have a surveillance system, because you have drug treatment, and if you have an environmental interventions as well. I mean, we've done a fair amount of modeling in different types of diseases, and that's usually always the case. And this is part of a new movement, which is, I think, a long overdue movement, to start looking at different public health problems as more systems problems. Because in the past, it's say, okay, let's throw a technology at it, or let's throw a particular intervention at it. And I think it's especially acute with NTDs because it's viewed, okay, well, resources constrained, we have to pick one thing. And that shouldn't be the case. We really need to understand that it's not a competition among technologies. It's really, okay, how do these fit together and what are the synergies behind it?
Great, thank you. I saw one more hand think over here. Yeah,
Can I be again?
sure.
This is more
There's nobody else,
and
right?
maybe a little bit complex. Let's see if I can phrase it correctly. So we heard a lot about the Institute of Health Metrics in Seattle, and they're the ones who generally, with their who knows what type of algorithm, they come up with some DALYs. And normally, none of us are ever happy with whatever DALYs they come up with because we think that for our diseases they should be better than for some others. And when we actually work with you, specifically, for example, with Chagas, and you do your modeling, and your modeling actually leads or yields, of course, much better DALYs, of course, for our perspective, or that in fact that the DALY is underrepresented from the IHMI versus the way that you do your modeling. And I always have a hard time explaining why is that. And is it because you're modeling towards the future? Is it because you model looking at the societal impact, and that's how you come up with the DALYs? What's the distinction, and why are there so many discrepancies between DALYs from IHMI versus DALYs that come out of, for instance, mathematical modeling?
So I think I wanted to preface all the comments by saying that the key things with when you're building a model are, one is transparency. It has to be very clear, what are the relationships, what are the things that are being represented and what are not being represented. So I think that's very important. So it's harder to speak for other models, but that's one of the things that we try to do. We try to make it clear, okay, if we're representing productivity losses, this is how we're representing it. And also, a second important thing is these models are important for elucidating relationships, more important for elucidating relationships than giving you a specific value. Because as we all know, if you do a particular forecast, if you say, okay, the stock market will be such and such in 2 years, it's usually wrong, right? But the order of magnitude might be on in terms of long-term and sort of long-term trends. It's hard to predict on a specific day what the exact value would be. So it's important to elucidate relationships. That's why a dynamic model is important, to show, okay, if you change this assumption or you change this value, this is how things change. So I think when you report a value that comes from modeling, it's very important to say, okay, here's the baseline values that we came up with, and then here's what happens if we change these variables. And so that people really understand, okay, I understand what you're trying to do. So that's what we've tried to do. I think a third thing is, with something like Chagas, it's a very long-term disease. So it's chronic disease, basically. You get infected, and then you don't start seeing sequelae until 10, 20, 30 years down the road. So if you're neglecting all those outcomes down the road, then you're really missing a big part of the picture. So we try to specify, okay, we're taking those outcomes, and then we are costing them out based on the healthcare costs and the productivity losses, and then we're discounting them, bringing them forward and seeing what the ultimate value might be. And so again, I can't speak for modeling efforts where I don't know the exact inputs, but I can tell you that a lot of the cost is going to come down the road, and they're substantial. So we all know that heart disease is a significant burden. So it shouldn't be unexpected that Chagas disease, which results in a lot of cardiac outcomes, is going to be a significant burden. That should make sense, right? Because you have congestive heart failure, you have cardiomyopathy, all those different things. So that contributes to a large percentage of the cost that we're seeing and the productivity losses. So if there are discrepancies, my guess is some of those may be accounted for based on, what are you really incorporating, like how much are you really accounting for these productivity losses that might be coming down the road from cardiac outcomes.
Thank you, Bruce. Carolina, you have the last word if you want it. Have anything to add?
No, I think that basically the take-home message here, I think, would be looking at this, comprehensive approach for neglected diseases, from trying to get the best RNT model that works for those diseases that are totally not following a very logic and profit-driven market. Also thinking about what they're doing with Sabin Vaccine Institute, like trying to look at vaccines that can have a broader impact in terms of maybe be streamlined with other public health initiatives as vaccination, vitamin A supplement, different things that can be also a way of integrating this tool. And then, of course, having a good surveillance system. And this, I think, will be different for each disease. Like for Chagas, if you can use dogs or other animals as a proxy for trying to come up with the prevalence. And I believe the last chain would be make available technologies accessible, because what we see in Chagas disease is that even though you have the tools, they might not be the perfect treatment options. We have serious problems sometimes in terms of tolerability of these treatments, but they exist and they can be monitored. And I think that there have been a lot of successes. MSF has published the feasibility of treating patients in remote areas for Chagas. And I think what we need now, and I think it's great that we're here in the policy school, is really try to develop policies that integrate the available technologies and make them accessible to patients. Because even if we have the perfect pill, but they don't get to patients, there will be no change in that. So I believe that really it's like a box inside of other boxes, and I think if we go and address each one of them, I think we might have success, and I believe success is possible, but I believe it has to be all integrated into one big approach.
Thank you very much. Before we thank our panel, I want to tell you we have a 15-minute break and then a 1-hour panel, and I think Peter will address some final words to us after that 1-hour panel. So take a break for 15 minutes, but before you do, help me thank our panel. Thank you.